Good afternoon, ladies and gentlemen. It's really my pleasure now to chair this state-of-art session. My name is Ibtisam Bais. I'm consultant internist and endocrinologist, and I have the honor to introduce our speaker in this session. Our speaker is Dr. John Flute. He is a professor of medicine, consultant endocrinologist at KHUH. He's trained at Oxford and Guy's and St. Thomas's Hospital, London, and his interest is neuroendocrine tumor as well as the relationship between body composition and cancer. He has at least 5 publications in that field and many more publications in the field of endocrinology. And his talk will be about endocrine hypertension. So the floor is yours.
How do I move? Okay, thanks very much. This is one of several areas of medicine I'm interested in, not from a cardiology point of view, more from endocrine hormonal point of view. And we're going to look at today the secondary causes of hypertension, which is the realm of endocrinologists. I worked in a neuroendocrine unit, or an endocrine hypertension unit in Australia for about 5 years as a lecturer, and learned most of my trade there. I'll quote some of the material from the professor of medicine who is now retired, called Richard Gordon, and that's where I learned a lot about cons, not so much about fields, it's much rarer. Now, hypertension is a very serious condition. I have divided it's a very serious condition with a high morbidity and a high mortality. I'm going to start my talk by looking at the epidemiology of hypertension. It's only about 5 minutes, but it needs to be done to introduce the topic. And I'm then going to look at secondary causes. Secondary causes are quite varied. They can be from renal artery stenosis, can be drug-induced. But the area I'm interested today in, I'm going to present to you today, is basically adrenal tumors. And the first 10-15 minutes we will look at cons and the different types of cons, and it's become more complicated over the last 20 years since the discovery of a large number of genes, and it's like the channelopathies in the heart. We have the same problem, the adrenal gland. And then the latter half of the talk will be about pheochromocytoma, which is extremely rare but much more dangerous than cons. And so to give you an example how rare it is, Prof. Naji and Munster and myself only have had one this year, or in 2021, in our clinic at King Hamad. So the incidence in Bahrain should be about 6 per million, and that means about 9 every year in Bahrain, but we only had 1. So it's other places, other endocrinologists may have seen them, or they've just basically been missed because they've been quite silent. Now, 1 billion people worldwide have got hypertension, and the US alone 50 million. It increases with age, and even if you're normotensive at 55, you've got about a 90% chance of developing hypertension by the age of 80. 46% of people who have hypertension don't even know they have it, and about 20-30% of people who actually have hypertension have very poor control. The mortality, 7 million people a year die from poorly controlled hypertension, and it is the commonest cause of preventable death in the developed world, and is the number 1 cause of congestive cardiac failure and stroke, and the second leading cause of renal failure. So it's a very serious condition, and it is one of the areas of medicine that's actually poorly managed, in spite of the fact that we have a world full of cardiologists, clinical pharmacologists, and endocrinologists, and even general physicians. Nevertheless, it's poorly managed, I'm afraid to say, if you look at the mortality associated with it, for lots of different reasons. Non-compliance is probably the main reason. As I said, as you get older, your blood pressure just goes up from decreased compliance of your aorta, and by the age of 70, 80, even 80, as the end of it flattens out at 70. Between 70 and 89, there's a flat line, and the incidence at that stage is about 70%. There is a gradation of it, and we consider blood pressure to be normal at 120/80, and it gradually goes up to grade 3, which we called in olden days malignant hypertension. One of the commonest forms of hypertension that's seen, of course, in clinical practice is isolated systolic hypertension in the elderly. And in young people, occasionally you will see diastolic hypertension on its own. Now, when I was a medical student in Galway, the textbooks said that, or stated that primary hypertension was basically essential. In other words, 95% of the time, there was no known etiology, and only 5% was secondary. But with the improvement in technology and genetics and physiology and imaging, the incidence of primary hypertension has gone right down to 34%. And with the increased incidence of obesity and obstructive sleep apnea and the associated hypertension and metabolic syndrome, that has now become the predominant cause or association of hypertension and metabolic syndrome, which is 64%. Primary hyperaldosteronism, which we're going to look at in a minute, this particular slide is 5.6%, but a large number of endocrinologists who are have done a lot of research in this area have actually shown that 1 in 5 people with hypertension, in other words 20%, have actually got cons, adenoma or hyperplasia, adrenal hyperplasia in the background as the cause. Now we know that this is all of this stuff is familiar, but as a preamble, I just want to get set the scene for the 2 adrenal tumors that we're going to look at. You're all aware of all the risk factors that predispose people to getting hypertension. The classical one, of course, is obesity, and simple obesity without any diabetes, you can get hypertensive with it from just being insulin resistant, and the high insulin levels produce in stimulation of the autonomic system, and you get vasoconstriction, and also it produces an effect on the mineralocorticoid receptor, so you get volume expansion. So the hypertension and obesity is a combination of volume expansion and increased peripheral resistance. Gets better or improves certainly with weight loss, like from bariatric surgery or whatever, or just basically dietary intervention. The odds ratio, so this first part of the talk is just to show you that increasing age, waist-hip ratio of giving you an odds ratio of 1.5 to 2.8. These are the important risk factors for hypertension in the general population: increasing age and central obesity. High salt intake has some influence. Alcohol in different countries has a different influence. Places like Russia, hypertension more than likely is predominantly alcohol related, and so on. Now, how important is it to, as regards risk? Well, if you start off even with a blood pressure lower than normal, you can, even in relation to normal blood pressure within the definition of it, your risk can change. So from 115/75 up to normal range and right up along, every time you go up 20/10, you double your cardiovascular risk. And then treatment is very important, and even though treatment, a lot of the time, as I've stated previously, is inadequate, it's still important to try and get people's blood pressure down as low as possible. So what is the influence of treatment? Well, the stroke rate drops by 40%, the myocardial infarction rate drops by 20%, and even more importantly, the heart failure rate drops by 50%. So it is really important to have good hypertension management. This is a summation of a number of studies I put together, and it just shows you that the risk for a cerebrovascular event is much more than it is as a risk factor for coronary disease. And as you can see, as your diastolic goes from 84 to 105, your stroke risk goes from 0.5 to 4, and the heart goes 0.5 to 2. So it's a much more important risk factor for cerebrovascular events than it is for coronary events. You don't want to see this, and this is not an unusual ECG in my clinic in Barts in Royal London, Whips Cross, where I worked for over 20 years. I ran a hypertensive clinic, and black Afro-Caribbeans, West African black population who immigrated to England, or Afro-Caribbeans who were the same genetic population coming to work in England in the 1950s, when they come in and hit middle age and get hypertension, this would be not an unusual ECG, even on treatment. And that would not be an unusual cardiac echo showing concentric hypertrophy. Now, there are a number of definitions we need to get clear before we look at the 2 tumors. And the idea of hypertension, which is secondary, is defined as secondary to, for example, an adrenal tumor, or from drugs like the oral contraceptive pill, and also from the new set of drugs that are used for modern cancer therapy, are also all associated with hypertension as a side effect. Now, pseudo-resistance is another concept that's used, and this is mostly due to poor adherence, and also poor blood pressure technique measurement. That leaves the last three on the right-hand side, and in hypertensive clinic you will see three different types other than the managed hypertension, which is basically the ones you don't worry about, and they are masked, quite coat, and true resistance. So masked is where they're hypertensive at home, and the white coat is when they're hypertensive in the clinic. And believe it or not, these are not benign conditions by any means. The masked hypertension is very serious, and 30% of these people have LVH on both echo and ECG. Now, the ones we're interested in today are the group what we call true treatment-resistant hypertension, and there's this very strict definition where the blood pressure has to be over 140/90, and the patient has to be on 3 drugs, including a diuretic. And this is how we defined treatment-resistant hypertension, of which adrenal disease is only one of the causes. The 2 adrenal diseases we're interested in are the 2 at the top, Conn's and pheochromocytoma. Now, you can get hypertension in children, and you get hypertension in adolescents, adult life, and also elderly. And the 2 tumors we're looking at today are predominantly diseases of middle age. If you can look at the 4th slot down, it says 40 to 64. And you see basically PHEOs in that particular group. What gives the physician the hint that they might have a secondary cause? Well, the problem is most of the time there isn't a hint. There is only a specific phenotype of patients that you see in some of the fields, but generally the phenotype in Conn's is just a normal patient who's got hypertension treated by the GP, and the GP hasn't quite copped onto the fact the patient might have an adrenal tumor, and this is a very common scenario. Occasionally you will get hypokalemia to give the physician a hint, or hypokalemia induced by diuretic therapy, but normally it's just a high risk of high. You just need to have a high incidence of just to be very vigilant to make sure that you have a reasonable approach to hypertension. So, for example, a young patient whose normal BMI, not black, with hypertension and on 4 drugs is somebody you would basically take particular interest in. PHEOs, again, 60% of pheochromocytomas basically are picked up incidentally and are come into the category of incidentaloma, which Prof. Najee Al-Munson is going to talk about tomorrow in the pituitary. But even so, a lot of these incidentalomas are picked up by CAT scans being done for diverticular disease, staging colon cancer, staging breast cancer, and they're sent to our clinic then because they've shown an adrenal lesion. Now, this is an important slide because this is the group we're really interested in. Who are the patients that you have to have a high who are the patients that you need to be suspicious might have a secondary cause? And they are obviously young people, children, adolescents before puberty, young people aged 30 who are non-obese, non-black, with no family history. And I've had several patients in this category. One particular girl from Shanghai who had a BMI of 16, and she was on, very slim university student, she was on 3 antihypertensives, and she turned out to have a very large Conn's adenoma. And then accelerated hypertension and also blood pressure that just all of a sudden, after years of treatment, gets out of control. Now, this is what you must do before you actually start looking for adrenal disease. So you must make sure that your patient is adequately treated, it's not white coat, that there's no other explanation why they're hypertensive, like, for example, obstructive sleep apnea and metabolic syndrome, that they have a high salt intake. Non-compliance is a huge problem. Very interesting paper by Brian Williams in UCL a couple of years ago at the European Hypertensive meeting in Berlin showed that if you are on more than 3 antihypertensive agents, the non-compliance is almost 100%. And then, of course, the last group are the group that we are going to look at now, which is basically adrenal disease. So you need to rule out all of these other conditions before you can we should start looking at adrenal causes. And the 2 adrenal causes are primary hyperaldosteronism and PHEOs. Now, the range is huge, as you can see, 8 to 20%. So that means 1 in 5 patients who have got hypertension have actually got Conn's, and I don't believe this figure. This is Gordon's figure from Australia and Strovaster's figure from the University of Queensland. More reasonable figure is probably the 8 figure, but again, this is highly controversial at the moment. The other causes, endocrine causes, we don't really have time to discuss today. Now, The commonest reason, or the commonest reason that, or the commonest scenario where these tumors are picked up, unlike previously, where you would have people with neurofibromatosis and basically von Hippel-Lindau screened, and because these are conditions in which there's a high risk of getting pheochromocytoma, and also the MIN syndromes, particularly MEN2. So you're looking at families who have higher risk anyway because of the genotype. But nowadays, the most likely way of picking up these tumors, both cons and pheos, is purely incidental. And the question then is, how do you differentiate between the two? Because of course, both can be totally asymptomatic. And there are ways of doing it. You can do it on CAT scan, you can do it by chemical investigation, but also purely by the incidence. So pheos are, as I said, in a country like Bahrain, you would only probably see 6 or 7 a year. We should be seeing 20% of our high percentage of the population in Bahrain should have Conn syndrome by definition. Now, the CT scan characteristic of a Conn's tumor is usually a non-contrast CT, and they have Hounsfield units less than 10 because it's a lipid-rich adenoma. And you've basically got rapid washout of when you do the contrast. Whereas, and the tumor is usually homogeneous. Now, this is what the textbooks say, but of course in real life it's not like that, and you can get caught out because, of course, we know, for example, that adrenal cancers can have high lipid content, and also secondaries from clear cell carcinoma of the kidney, which is part of one of the syndromes, can also have it. So you need to be very careful, being absolutely certain that you have a consanguinoma on your hands. And you really have to go on size then, and a lot of other ways of investigating, which we'll look at in a minute, like adrenal venous sampling. But anything over 3 to 4 centimeters, you have to presume it's more than likely going to be an adrenal cancer, which are very aggressive, with what they're called adrenocortical carcinomas. They can actually make aldosterone and be very lipid rich as well. And the rule I have in my own head is anything more than 4 centimeters, you have to presume it's an adrenal cortical carcinoma, even if you got hyperaldosteronism on your plate. A brief description of anatomy. This is all familiar because we're all endocrinologists, but I'm put it up to remind myself to tell you that normally aldosterone comes from the outer layer, the zona glomerulosa, and cortisol comes from fasciculata. But when you get an adrenal adenoma, this definition of layering disappears, and the fasciculata starts to make aldosterone as well, because the enzyme aldosterone synthase is actually found not just on the outer layer, but in the second layer as well, and becomes then ACTH responsive. Most of the time, you do not get any symptoms in primary hyperaldosteronism to alert you to the fact that the hypertension is caused by an adrenal tumor rather than being primary hypertension. But as I said in the previous slide, there are a number of characteristics that are there that should alert you. And when I was working in the UK, I was amazing how often GPs would have young patients 15, 20, 25, 30 on hypertensive agents for years and years and not become alerted to the fact that this is a bit odd. And the patients will come in for lots of other different reasons. So this young girl from Shanghai, a university student in London, comes into casualty paralyzed in Whipps Cross, potassium 1.8, and the consultant made a diagnosis of hypokalemic periodic paralysis, which is, of course, as you know, found in Chinese, Japanese population associated with thyroid disease. She was given replacement, sent home. Boyfriend brings her in a week later, same thing again, paralyzed, and I happen to be on. And of course, being an endocrinologist rather than a general physician, one is more alert to other causes than the fancy stuff. So she had a huge Conn's tumor and renal calcification from years of hypokalemia, and was on 4 antihypertensives, and as I said, she had a BMI of 16. So, you know, this is what happens. The GPs are so busy, they don't, the penny just doesn't drop. It's easier for people in endocrinology, of course, because that's how our minds are programmed from years of education in the area of endocrinology. Now, Conn's is predominantly is just caused by hyperplasia, where on both sides, the cells are just bigger. But it's never as clear as that, because if you start looking at the literature, you'll find that you can have an adenoma in one gland and have hyperplasia on the other side. You can have micro nodules on both sides or on one side and an adenoma, or you can have macronodules. So this definition is not quite as clear as implied in this slide. 1/3 are adenomas, and we're going to look at the way to actually differentiate between these two causes of hyperaldosteronism. Now, it's very straightforward. Patient's hypertensive. You may not get hypokalemia. This patient fits the phenotype that suggests that the hypertension is a bit strange in somebody who's young, and you do renin and aldosterone ratio, which is the middle block there. And if you're making too much aldosterone, it switches off renin, and the diagnosis is made by looking at the ratio between the two. And this is a universal screening test that's done. And the ratio is usually, it's different here because we use American units, but in the UK it's greater than 700. You need to make sure though that the potassium is over 4.5 because of course the most important secretagogue for aldosterone is extracellular potassium, and a lot of the time the cons is missed because the patient is hypokalemic and just given replacement and the test is done before the replacement is introduced. One of the commonest ways of the whole thing getting mixed up is the patient is hypertensive on a diuretic, and that will give you high renin, high aldosterone. But and again, you know, the range of the renin can be just a little bit above or below the normal range, and so on. So it can get very confused. So you do need to take them off diuretic therapy for a short period of time before you actually get a reliable renin aldosterone ratio. So what do you normally do then? So you've done, you've picked up the patient, you've realized that they possibly have an adrenal adenoma. You've done the CT scan. The CT scan report comes back, confirms the possibility of an adenoma, and then the next thing is, do you go for surgery? Do you go for pharmacology, and so on and so forth? And that depends because for several reasons. Number one, you can't just put them on mineralocorticoid, even you should start them in the beginning on mineralocorticoid receptor antagonists. That's the first point. Second point is primary hypertension and hyperaldosteronism, even for the same blood pressure, are not the same disease. There is a much higher mortality in patients who have got the same level of blood pressure compared to primary hypertension. And that's because the aldosterone is not just causing water retention, it's also causing fibrosis in the heart. It's also causing cardiac dysfunction. They have a much higher incidence of strokes. They have much higher incidence of atrial fibrillation because of left ventricular dysfunction and so on. So it's a much more serious condition than primary hypertension for the same level of blood pressure. So if you've got a young patient who is less than 35 and you've got a good size adenoma on one side, there's no real reason to go on to do adrenal vein sampling, and you can go on and just do unilateral laparoscopic adrenalectomy. Now the outcome and the blood pressure response to adrenalectomy, to tumor removal, is much better than mineralocorticoid receptor antagonists. They're not the same, even if the blood pressure is roughly the same, they're not the same as regards long-term outcomes. So if you have an adenoma, even if it's less than one, even if it's not particularly big, it's advisable to take it out. This idea of just taking out the adenoma itself is not a valid way of doing it. You have to take the whole adrenal gland out because you're not sure that that is the actual source of the aldosterone if you haven't got AV sampling. And even inside in the gland itself, there might be another focus for the excess aldosterone. When the patient is over 35, then adrenal vein, and you've got pathology on the other side. So you've got one side an adenoma, and on the other side you've got, say, micronodules. You then have to decide where the excess aldosterone is coming from, and this is where adrenal vein sampling comes into as a help for its management. The problem with it is that it's not available in Bahrain. It's not available in quite a large number of places. It's a highly skilled way of investigating the source of the aldosterone. If not all radiologists can do it, and it has a certain amount of morbidity attached to it. For example, you can cause hemorrhage into the adrenal gland. You can misplace the catheter. You can put the catheter through the inferior vena cava. So it's not quite as innocent procedure as people make out. But if it's done by a very skilled radiologist, it's a highly successful way of and very helpful. When I worked in the endocrine hypertension unit in Australia, I came up with a protocol that most people would not use probably, but it is a highly efficient way of diagnosing cons. And the difficulties arise in that we don't all have the same level of euvolemia every day, and also the potassium will vary enormously according to how much aldosterone excess you have. So you have to make the playing field level, and the only way to do that is to bring the patients in for 5 days. And what you do then is, they've been previously screened for renal aldosterone ratio. It's described as being abnormal. You bring them in and you basically stop all their antihypertensives, and you can leave alpha blockers, but you have to stop beta blockers, ACE inhibitors, angiotensin receptor 2 antagonists, and so on. You've got to bring the potassium over 4.5, and you've got to load them with saline. Usually I give them 3 litres. Then on day 2, they rest overnight and they have an 8 AM electrolytes renal aldosterone ratio done, and then a mobile for 2 hours, and it's repeated, and it's done on day 3 exactly the same. Now the reason you do this is because when we all stand up, our angiotensin 2 levels go up to cause vasoconstriction. And we know that hyperplastic adrenal cells express more angiotensin 2 receptors, and therefore at 10 o'clock, the level of aldosterone goes higher than it was at 8. The renin is suppressed both samples. Then the next, you do that, and then you do, I usually do it again the next day, because the next day you need 2 sets of samples just for reliability. If you've got an adenoma then, as a contrast to the hyperplasia, the adenoma cells, the adenoma tissue itself expresses more ACTH receptors. Therefore, instead of going from 8 o'clock sample, say the level is 10 to say 40 at 10 o'clock, it goes the other way around. It goes down at 10 o'clock. That's because of circadian rhythm and ACTH. So even before you've done a CT scan, you can actually decide, purely on the basis of chemistry, whether the patient has got an adrenal adenoma or hyperplasia. Day 4 is an important test because 6% of Conn syndrome is actually caused by genetic errors, what we call the channelopathies in cardiac disease. Same applies to the adrenal gland. There's a large number of, something like 6 or 7 different types of channelopathies in the adrenal gland, which are now well described, particularly by Italian groups at Cremona and at the University of La Sapienza in Rome. Of all different types of chloride channel, potassium, sodium, and so on, which I'll show you in a minute. And even there is a form of Conn's that is actually dexamethasone suppressible, and that's why you got to do a day 4 dexamethasone suppression test. So you get them 10 o'clock the night before, you can get them 2 or 4 milligrams of dexamethasone. Following morning, you measure renal aldosterone ratio, and I'll show you the chemistry of this in a minute. And this is called glucocorticoid suppressible hyperaldosteronism, and it's not treated by spironolactone or alpranolone, it's treated by steroids. And day 5 then, you then make the decision, discussion with the patient, whether you want to do selective venous sampling. Now, so far we have seen 2 types of hyperaldosteronism. One is where you get hyperplasia, and the other one is the adenoma, and that's well described in old literature. But in the last 20 years, with the onset of with the progress and developments in genetics, people are now identifying channelopathies in the adrenal gland, just like you got them in Bermuda and the different arrhythmogenic conditions in the heart. And the initial group are just 4, and we'll just look at 4 very briefly, just to show you the mechanism behind it. But it's actually gone up to 6 or 7 now, and I'll just briefly mention the 6th and 7th to you, just in passing. We're going to spend a little bit of time looking at FH1 because it constitutes 6% of all causes of Conn's, and it's very commonly missed. And it's a hybrid gene between B1 is the 11-beta hydroxylase that makes cortisol, and that's in zona fasciculata, and then aldosterone synthetase is B2, and that's in glomerulosa, the outside layer. And what happens is you fuse the 2 genes genetically, and the control side is B1, and the synthesizing side is actually B2. So you're making aldosterone under the control now of ACTH rather than under the control of the renin system. The next type is a chloride channel problem. We'll look at that in a minute. Next one is potassium channel problem, FH3. FH4 is calcium. And then the other ones are 5 at the second from the bottom is this one associated with epilepsy and neurological problems, particularly mental retardation. And then the last one is a very recent one called the armadillo gene, which I don't have time to talk about today. This is a cartoon of what basically an adrenal glomerulosa cell would look like. And it's very interesting, and it's beautifully done. It's not my creation, of course, I got it from the literature. But what's interesting about it is that it delineates all the different types of familial forms of hyperaldosteronism. And I haven't time in this talk to go through every single one, but I'll cherry pick 1 or 2 to show you how things work. So the three secretagogues for aldosterone are ACTH, a rising extracellular potassium, and angiotensin II. Now the rising potassium is the most potent, and the membrane in a adrenal glomerular cell is normally hyperpolarized. But when you get potassium entry, then what happens is you get basically a calcium channel opening up. Calcium gets in, and if you look at 12 o'clock, where the blue is, which says calcium, you see depolarization goes into the DNA, and you get basically aldosterone synthesized, and you get it being secreted. In the DNA depiction here, you can see they have got the gene B1 and B2. So B1 is the one that controls cortisol synthesis, and B2 is aldosterone synthesis. And you can see it's a hybrid gene that responds to ACTH, and the ACTH is over at 9 o'clock, as you can see, through adenyl cyclase, the receptor protein that goes into the DNA and then makes aldosterone. And this is glucocorticoid suppressible hyperaldosteronism. The other type we'll just go to the one at the top called FH3. Now FH3 is very interesting. The adrenal glands in these usually pediatric population, kids under the age of 20 or adolescents under the age of 20, very severe hypertension, massive big adrenal glands, and the treatment for this is, believe it or not, bilateral adrenalectomy, because they just don't respond to any other form of therapy. What's interesting about it is that we're looking in all of these cases to a gene error. And gene mutation causing all of these particular abnormalities, and the genes have all been identified. But in the non-genetic forms of adrenal adenomas, 80% of them have got the KCNJ5 mutation in the actual tumor, and that's called a somatic mutation. So there is a very interesting overlap between non-genetic forms of CONS and these familial forms that have been identified over the last 20 years. Just to briefly, A depicts normal physiology of potassium, angiotensin II, and how it stimulates aldosterone synthesis. The glucocorticoid one is B, and you can see you got this chimeric or hybrid gene. And then C, as you can see, you got a mutant potassium gene that basically allows sodium in, and once you get sodium inside an A cell, muscle cell, heart cell, you get depolarization, and you get calcium channels opening up, and you get B2 enzyme making aldosterone. So all these mechanisms have been very well worked out, and if you go to the European Endocrine Society meeting, which is in Milan this year and going in May, all this stuff is just there in huge amounts. Now, the typical biochemistry result that comes back is as described here, and this thankfully shows a suppressed renin and an aldosterone that doesn't quite fit the range. As you can see, it's within the normal range. Now I put this up and created this simply because it's absolutely vital that the potassium is over 4.5. Because a hypokalemia attenuates the aldosterone response in all the physiology tests that you do, as I've described in my 5-day profile. So in summary, CONS is now much more complicated than it was 20 years ago when I was training as a registrar in endocrinology in Oxford. It's become really complicated, not because doctors have got better at it, but because the science of medicine has infiltrated our specialty, and genetics has really made a huge impact in defining the genetic causes of CONS syndrome. Number two, it is now probably thought to be a much more common cause of hypertension than previously thought, up to 20%. Number three, surgery is very important in removing adenomas, and surgery is much more efficacious than medication in actually improving the response to treatment. In other words, all these patients do not always go back to normotensive state. Now we're going to look at adrenal vein sampling really quick, just to give you a flavor of what it's like. So the normal adrenal anatomy, you're all familiar with this. We use 3 pigtail catheters. They're called pigtail because they've got a tail on them to stop you from penetrating the cava. And when they go in through the femoral vein, they straighten out. The right adrenal vein goes straight into the cava. The left one is the devil, because you have to go into the left renal vein and then you up into the left the left adrenal vein, but unfortunately the inferior phrenic drains into it, so you get a dilutional problem, and that's why when you measure aldosterone and selective venous sampling, you have to do a cortisol as well. You also measure cortisol because some of the adrenal adenomas, especially over 2 centimeters, are co-secretors of cortisol and aldosterone together. Now, the obvious question is, well, if that is so, why don't we have a cushingoid picture in cons? Well, we don't, because the level of cortisol in excess is actually suppressible by dexamethasone suppression test. But if you follow these patients, the studies all show they have an increased incidence of osteoporosis, they have an increased incidence of metabolic syndrome and insulin resistance as well. They're not frankly cushingoid, but they certainly have consequences of the hypercortisolemia. This is what the catheter looks like on image intensifier. As you can see, it goes up into the left renal and then into the right side. This is a typical result. As you can see, you've got a tumor, theoretically, this is a cartoon obviously, you've got a tumor on the left side, you've got an aldosterone cortisol ratio of 15.6, the opposite side is 2.4, and you get a background from the cava. Now you need to do this because it's not just, you need to do this because the other side might have micronodules, and the micronodules can be very, very productive of aldosterone. So just because you got an adenoma, it doesn't imply or doesn't mean that's the site of the excess aldosterone. That's the typical, and you get a ratio between one side and the other. So that's cons, and the 3 or 4 points from cons are: number one, you need to look for it. Number two, it doesn't have a phenotype, so you have to be suspicious in a certain sector of people who have hypertension that don't fit the proper picture of middle-aged man who's obese. Number three, adrenal venous sampling is reserved for a situation where you've got an adenoma on one side and pathology on the other, and it's not applied to all patients. Number four, you get a better result with adrenalectomy than you do with basically mineralocorticoid receptor antagonism in cons. And number five, if you are in any way suspicious, you should look for a genetic cause. It constitutes almost 1 in 10 of cases now. Granted, it's in the usual pediatric population more than in the adult. Now pheochromocytoma is a different story. Cons won't kill you immediately, but certainly pheos will. As I said, with describing Prof. Naji's talk tomorrow, incidental-omas, 60% of pheos are now picked up incidentally, where people have a scan for staging of cancer, diverticular disease, and so on. In other words, they're a silent killer just waiting to to kill you, basically. So how dangerous are they? Well, I gave a grand presentation many years ago of 2 young women, not the same year, back to in 1 year and the following year, I can't remember the actual year, who both died during labour in the Mater Hospital maternity ward. Both had a cardiac arrest in the middle of labour, and both post-mortem showed pheochromocytomas. And this is the type of situation where the hint in this type of patient is that they're normotensive and then become hypertensive in pregnancy. And the golden rule is you should look for a cause other than the pregnancy to make sure that you don't miss something like a pheo. And in both these cases, unfortunately, both women died, as did the babies, and they were both in their 20s. And this is an important story because the release of catecholamines from pheochromocytomas doesn't behave like a normal adrenal gland. It's released. Normal adrenal gland has got cholinergic innervation, it's got blood vessels and so on and so forth. But the cholinergic innervation is the important bit. The pheochromocytomas don't have any innervation at all on basically electron microscopy. They have no nerve endings. So the release of catecholamines is based on blood flow. So anything that increases intra-abdominal pressure will cause the release of catecholamines unregulated, and that's what happened during labour in these two poor women. Now, as a contrast to cons, pheochromocytomas does have a phenotype, only though when it's associated with a syndrome. So if you have got patients like von Hippel-Lindau and neurofibromatosis, or a family history of MEN2, or Sturge-Weber's, or any of these, you've got to look for pheochromocytomas. And how common are they? Well, in MEN2 it's 50%, 100% medullary carcinoma of the thyroid in MEN2, which dictates the outcome of the disease. If the medullary carcinoma of the thyroid is aggressive and very malignant, and then these people die from that part. They don't die from the pheo as such. But half of them will have a pheochromocytoma. Neurofibromatosis is a bit less, it's 3 to 5%, and von Hippel-Lindau is about 20%. There is a classical, algorithm, if that's the word, to describe that, what's called the rule of 10, but it, of course, is completely contradicted by later studies, in that 10% are malignant, 10% are bilateral, and 10% are extra-adrenal. That doesn't apply anymore, but with all the advances in imaging and so on, this has been shown to be completely incorrect. But for the moment, we'll just describe it as that, and I'll show you where the divergence occurs. If you have palpitations, headaches, and sweating as a combination of symptoms, you're looking at 95% sensitivity and specificity. But of course, half the world suffer from palpitations, headaches, and sweating on an average day going to work. So it's very, very unreliable as a screening test. But if they come perfectly together in paroxysms of 20 minutes, it is a very convincing story. One of the most important rules I tell my students is that you get the relative in, the daughter or the mother or the sister or the husband, and ask them what the patient looked like during these paroxysms, and they usually are very, very pale, as a contrast to carcinoid, when their paroxysms are, their patient looks red because their paroxysms are, they vasodilate. So they have a specific appearance. You're all familiar with the classical scenario of the classical combination of symptoms. 1/3 of patients with PHEOs have got diabetes from they got hyperglycemia. The figure here is 20 to 40, but the recent paper I read was about 1/3. You can get weight loss, you can get constipation, believe it or not, rather than diarrhea, and also you can get hypercalcemia. Because catecholamines can stimulate calcitonin release, and that gives you hypercalcemia. In most cases, you should have hypertension, but it's not always there. So you can actually get orthostatic hypotension, and also, as a contrast to cons, your ECG and echo can be normal because it's a paroxysmal explosion in vasoconstriction hypertension, whereas in cons it's a volume expansion and chronic hypertension. So the ECGs are more abnormal in cons and can be perfectly normal in PHEOs. A number of drugs interfere with the assay. The assay, as you know, is 24 urinary catecholamines. You need to do it 3 or 4 times. You need to do it, and you need to get results 2 to 3 times above the upper limit of normal. The commonest explanation nowadays of an abnormal urinary catecholamine is noradrenergic reuptake inhibitors, which are antidepressants. It gives you high noradrenaline output. Levodopa cocaine, levodopa in Parkinson's patients. So there are a certain number of drugs you have to stop before going and doing the urinary assay. Plasma catecholamines are good for kids. Kids, very hard to do urine collection in kids. I don't tend to do plasma ones. It's got a half-life of about 60 seconds. Urines are much more reliable in adults. But remember, in ITU patients, you can get a high catecholamine output. So in ITU patients, looking for PHEO is unreliable. And also in advanced renal failure, you can get a very high noradrenergic urine levels of noradrenaline in the urine in stage renal failure. So you just need to be aware. Lots of things can actually interfere with your your interpretation of catecholamines. Now, this is just a very brief slide, as you can see, why dopamine could interfere with the assay. This is an important slide because PNMT, phenylethylamine N-methyltransferase, is only found in the adrenal gland, and that methylates noradrenaline to adrenaline. So that adrenal gland tumors, so the pheochromocytomas outside the adrenal gland predominantly make noradrenaline. They're called paragangliomas, whereas adrenal PHEOs predominantly make adrenaline. Can make both, of course. The more aggressive PHEOs can also make dopamine. Urinary catecholamines, you're all familiar with this. Now let's look at the syndromes quickly. The syndromes are divided into 2 clusters. One where it's related to tyrosine kinase, and that would be the red one at the top. NF1 would be another one. And the other cluster then is related to hypoxia, a condition called pseudohypoxia, and that's succinate dehydrogenase and von Hippel-Lindau. Von Hippel-Lindau, you're all familiar with hemangioblastomas in the eye, the spine, and so on. They get pancreatic lesions, they get PHEOs, they get renal cell carcinomas in about 30%. There's a very well-described classification into different types, but be aware, 2C, you have got a PHEO, you've got the gene for von Hippel-Lindau, it's about 300 different varieties of mutations, but you don't necessarily have to have the phenotype of a PHEO. Von Hippel-Lindau, neurofibromatosis type 1, this is a very famous TV presenter in England who's got very bad NF1. NF1 is the one that's associated with PHEOs. One of my last patients in the UK who came in with a chest infection, he had NF1, and I joked with the registrar, let's just do a CT in his abdomen. Sure enough, he had a pheochromocytoma, totally normal blood pressure, totally asymptomatic. So again, makes the point I made earlier. These are the cutaneous manifestations of NF1, leash nodules, sphenoid wing abnormalities. They can look like they've got thyrotoxicosis and cafe-au-lait spots and so on. Sturge-Weber's again. Now, the last part of the talk is very brief, about 5 minutes, and this comes to the point about FEOs. So you have major diagnosis, you've got an abnormal CT scan showing a heterogeneous lesion with hemorrhage and calcification, and it doesn't look like a Cons. It lights up the light bulb type in 11%, which I'll show you a scan briefly in a minute. And then you've got the high urinary catecholamines, and then you've got alpha beta blockade, and you've got laparoscopic removal, and so on and so forth. Then you're left with the problem about whether you can tell the patient this is a benign condition or a malignant. You can't rely on histology. The histology shows pleomorphic cells, some mitotic divisions in some of the cells and some vacuolation, but it's highly unreliable as a way of describing malignancy. So the 10, 20 years ago, a guy called Wallenberg, who got a Nobel Prize for his work, came up with this idea that most cancers are caused by abnormality of the enzymes in the TCA cycle, Krebs cycle, as you see here. Now, he didn't turn out to be correct because it's not 100% universal fact, but he did, his ideas were then translated into looking for this, see whether there's a relationship between Krebs enzyme abnormalities and cancer, and in most cases it was incorrect, except in the case of FEOs and paragangliomas. And of course, it's now one of the main areas of investigating and showing whether they're malignant or benign FEOs. So briefly, the enzyme succinate dehydrogenase converts this reaction, succinate to fumarate. 2 electrons come off, and they're transported up along the succinate dehydrogenase enzyme, which is actually embedded in the mitochondrial membrane and also inside the mitochondrium. So A and B subunits are the catalytic site, and C and D anchor it. The electrons then go across into to quinoline and complex 3, carbon dioxide motor and energy and so on. Now, if your succinate dehydrogenase enzyme is not working, then the succinate builds up. And succinate then blocks an enzymatic reaction, which I'll show you in a minute. We'll go along here. So normally, to go back to Wallenberg's hypothesis, in a normal situation where you've got normal oxemia, plenty of oxygen in your body, you do not need hypoxia induction factor, which is HIF, so it's switched off. So this enzyme, PDH, adds a hydroxy group onto hypoxic induction factor. Von Hippel-Lindau comes along as a ligase, binds to it, its ubiquitization occurs and it's broken down. That's a normal oxemia. You do not need erythropoietin gene or anything else switched on if you've got normal oxygen concentrations. Okay, you go high altitude, and we know, for example, paragangliomas are more common in the Andes in South America and so on. Most of the papers on paragangliomas come from South America. And when you become hypoxic, then the HIF is not broken down. It goes into the nucleus, stimulates DNA, and makes erythropoietin. You get cell proliferation, red cell proliferation, and this is the physiological response to hypoxia. That's called the hypoxic event, hypoxic signaling, and then it's switched off in normoxemia. In cancer cells, you've got a condition called pseudohypoxia, where the environment, even though there's plenty of oxygen around, the cancer cells behave as if there isn't, and this whole thing switches on, and it makes, and HIF not only makes erythropoietin, but it drives cell division, it inhibits apoptosis, it drives MYC oncogenes, and so on and so forth. So it's highly carcinogenic, as you can see from this slide here. The right one shows breakdown, and the other one shows when you're hypoxic that you would actually make erythropoietin. So that explains the relationship between succinate dehydrogenase enzymes and genetic analysis and pheochromocytomas. What you do now is once the pheo is taken out, the blood pressure gets better, you then send it off for genetic analysis, and it'll come back and it'll give you A, B, C, and D. And we know, for example, 97% of people who are SDHB positive have got a malignant pheo. How does that translate into a pediatric group? In the pediatric population, for example, in extraadrenal pheos, if it's more than 4 centimeters, if it's extraadrenal and it's SDHB positive, 74% of those tumors in kids are malignant and will cause real trouble down the line. So in summary, FEOs, more dangerous, much rarer than cons, very dangerous to operate on. You need good pharmacological blockade, you need good genetics afterwards to decide the outcome, and so on and so forth. And cons, not quite as malevolent, but certainly needs good treatment and good investigations and with adequate radiological support, and basically the decision then made whether you're going to do AV sampling. The last 4 or 5 slides is all radiology. I know I'm running out of time, so I'll be 2 seconds. The normal adrenal gland is as follows. That's a cons adenoma. It's homogeneous, less than 10 Houseville units, lipid rich. That's another one on coronal section. That's what it looks like on pathology. It's yellow. This is the light bulb sign for a FEO. Occurs in 11% of FEOs. Is highly diagnostic of pheochromocytoma. That's one like the one Prof. Nagy and I managed last year. Big cystic lesion, heterogeneous like this, typical of a FEO, but it could be a clear cell carcinoma metaposit or even adrenal carcinoma. So these are harder to differentiate from. They're much harder to differentiate compared to cons adenomas, because the cons adenomas are almost homogeneous. Necrotic tumor. Last couple of points. Paragangliomas are tumors of the adrenal gland, tumors of the chromaffin tissue outside the adrenals. You can get them in the neck, chromaffin tissue in the neck, in the carotid body. They're non-catecholamine producing. You get them along the adrenal. You can get them along the autonomic system in the abdomen, and there, of course, they secrete catecholamines, predominantly noradrenaline, like a FEO in the adrenal. The one at the bottom here is in the glandular zuckercanal at the aortic bifurcation. That's one in the pelvis with necrosis in it. That's the very necrotic tumor. Histology had no help. Last point. Patient from New Zealand, works as a graphic artist, had a FEO taken out in University of Otago at the age of 7, comes to England, gets married, has children, starts getting difficulty swallowing, gets a bulbar palsy, sent to the neurology clinic in Charing Cross, then is defined as having a right hypoglossal and a left 10th of vagus. So bulbar palsy is diagnosed. As you can see, he's a lump on the right side of his neck compared to the left. The lump on his neck, so this is his hypoglossal palsy on the right, and he's bitten his tongue from it. And you see how smooth it is compared to the other side. He had a chemodectoma in his neck, which is carotid body tumor, and Mr. Evans took this out, a Welsh surgeon. As you can see, the bottom bit is the carotid bulb, external carotid, and this is the chemodectoma in between. And this is why he had a bulbar palsy. He had a base of skull, pheochromocytoma, and that loop around it is basically his brainstem. And it grew over 10, 20 years. He had no neurology. I actually had medical students with me. We went over his neurology very finely. Plant responses down, going normal, more power, but obviously bulbar problems. A lot of neck pain, and you can see he was invading C1 and C2 and causing pain in his neck, which was the C2 dermatome. Transoral approach at Queen Square. This is the residual tumor, and basically did very well, improved dramatically, except he got a massive pulmonary embolus post-op, which we couldn't treat. Now, so this is an example of somebody who has multiple pheochromocytomas, one the base of the skull, and chemodectoma, paraganglioma associated with it, and then finally he had one in his tummy as a child. We'll skip all this. Last point. There are a number of cardiac abnormalities now associated with FEOs, particularly hypertrophic cardiomyopathy, not obstructive, hypertrophic cardiomyopathy, which actually reverses when you actually take the pheochromocytomas out. And there's a lovely case of a 12-year-old boy in the BMJ a number of years ago. And last point is this condition, Takotsubo's, is now been described. It's described after the vase they used to catch octopuses in Japan. And Takotsubo's, as you know, is a stress-related cardiac abnormality. It's got a whole fair degree of rigorous criteria for definition. But there's been a number of cases of elderly women, particularly elderly women who come into hospital in the UK, who have been asked about, has your husband died, has somebody else died, and the answer has been no. And they've had Takotsubo's. And of course they turn out to have basically a pheochromocytoma as the cause. These are all the definitions of Takotsubo's. Classical ECG of it. My final bit, I have to celebrate my third year in Bahrain, which I absolutely love, and I have to reveal the other side of my interests, which is art and particularly culture. And I love Islamic culture and poetry. This is the Great Mosque in Cordoba, using the columns from the Visigothic church on which it's built, 7th century. This is the beautiful woodwork on Cappella Palatina in Sicily, which was, of course, the synthesis of Byzantine motifs, which you can see at the back. The dais is at the back. The roof is done by Arab craftsmen, and of course the church is Norman. This is the Mevlana Museum in Konda in Turkey, and this wonderful man is buried there called, wonderful Sufi poet called Rumi. There's Rumi, beautiful depiction of him. I like this by him. Be empty of worrying, think of who created thought. And of course, this is the last chap. I love his poetry. He's a Sufi poet from Shiraz in Iran, Persia, and his name is Hafiz. He was actually a baker's assistant, 12th century. Here, this is his poem, Rubaiyat 29. I long for your hug and kiss. I want the wine that will bliss. Let me cut the story short. Please return, 'cause you I miss. That's his mausoleum, and that's the roof.
Thank you very much, Dr. Jean, for the excellent talk. And we are sorry because of the time.
That's about 50% of what I had when I prepared.
So now, because we are behind time, if you have one quick questions or so. Anyone have got any quick questions? Yeah, but quick questions and quick answer. It's up, Doctor. Mike. Mike.
Is there any place for other antihypertensive medications if the blood pressure is not controlled before
I'm a bit
surgery?
deaf, sorry, you'd have to talk a bit louder.
Can you raise your voice? Can you talk to the mic? Because we can hardly hear you.
Okay, sorry. In patients with FAO or paraganglioma prepared for surgery, in addition to alpha blocker followed by beta blockade, is there any place for other antihypertensive?
It's a good question. It's a good question, and I avoided the question to that aspect of it today because it's hugely complex. So if you look at the series done 20 or 30 years ago, I looked at an Indian series. Now, it's no reflection on India. They have just huge population. But the mortality, the operative mortality, was horrendous. About 1 in 2 patients died at the operation. And the reason that they had such a high mortality was nothing to do with the surgery. It was got to do with the pre-operative preparation, of which you just made the highlighted here. The most important bit is you fill them up with fluid, because when you actually take the tumor out, so you compress the adrenal veins first, you clip them, and then the artery. And what happens is the blood pressure just goes down into their boots and they arrest. So the anaesthetists get very, very worried, of course, by in trying to manage these operatively, because it's the anaesthetic side that's dangerous rather than the operative part. So what you do is you've got to fill them up with probably 3 or 4 liters every day for a week beforehand. And you shouldn't use phenoxybenzamine, because phenoxybenzamine is it binds to the alpha receptor too avidly, whereas doxazosin it basically doesn't bind as avidly. So doxazosin and beta blocker are basically what I recommend. I have to be very sensitive about what I say about Bahrain, because of course I work here, but the surgeons here refuse most of the time to actually tackle these as a tumor, and I personally think that they just need to get their act together. You know, this is not that difficult. They just need to go off to Berlin or Munich and go and learn how to do it. You know, sending patients with FEOs overseas to me is not good. And it's not that complicated. You just need adequate training and exposure to it. And it's usually, the mortality now, of course, is very low. And our last patient, I'm afraid, went to Stuttgart rather than being operated in here, which I think was, that was their decision. But anyway. So you're right, adequate fluid replacement, alpha beta blockade. Never start off with, with beta blockers. That's, you get a hypertensive crisis. And then an anaesthetist who's got some grit, because the anesthetic guy that's going to have the heart attack, not the surgeon, and so on. My experience is it's not significant, but I have a lot of experience. And in Charing Cross, the anaesthetist used to do it in pairs, because they were so worried the patient would have a hypertensive crisis on the table when the tumor was being manipulated. They're very, they can, and it's the small ones that are the dangerous ones, not the big ones. And they would always do it in pairs. They'd have 2 consultants doing it. So it just shows you how dangerous this type of tumor is to play around with from an anesthetic point of view and also from a surgical point of view. But mechanically, it's not that difficult to remove. It's just the pharmacology that's dangerous, and so on.
So with that, I would like to thank you very much, Dr.
All right.
John, and present this to you on behalf of Dr. Wiam and the organizer of the conference. And I would like to thank all the audience, particularly those who stayed with us till now, and we'll see you tomorrow sharp at 9 o'clock.